Okay. Um, does that work for everybody?
Yeah, we can see
Uh,
it.
you can see it. Good. Well, thanks so much, Michael, for the introduction and for hosting this show. I want to thank Stephen Shore for putting this together, and special thanks to John Papadopoulos, who is the IT guy and just incredibly skilled and patient. And it's a pleasure to work with all of you. So, today, I want to talk about the American healthcare system, and it's a bit of a moving target right now, as the United States is a moving target. I've spent the last 25 years or so um, exploring how what doctors take as knowledge has been captured by the drug industry and other industries, and I'm going to talk about that today. But we have to remember, and I'll talk about this at the end of the lecture, that now we're on new territory, and it's not just how the commercial interests have captured medical knowledge, but now we're going to be entering a period where there's going to be an attempt to save money in order to support tax cuts. So I want to make sure that everyone understands that we were in a crisis 3 months ago, and that crisis is about to get worse in my estimation, not better. So the best way to just get an overview picture of what's going on with American healthcare in comparison to the other wealthy countries is a comparison to Canada, our northern neighbors. Canadians live 5.9 years longer than Americans in good health. 5.9 years. Now, if we have a therapy, cancer therapy, that say extends life for 6 months, that's a major breakthrough. And we're talking about the average Canadian living 5.9 years longer than the average American. And on a per person basis, in order to achieve our inferior results, 5.9 years less of good health, we spent twice as much as the Canadians did per person, $12,555 versus $6,319. And if we spent the same amount per person on healthcare as the Canadians did, we would save $2 trillion per year every year, which is more than the annual US budget deficit. It's an enormous amount of money that we're spending in order to get inferior results. And I'm going to talk, the first part of my lecture is going to describe this situation. Then I'm going to talk about why this dysfunctional system is stable. And then finally, I'm going to talk about how we can repair the commercial intrusion into our healthcare and what we have to do to prepare ourselves for what's coming in the future. So there are three ways to measure life expectancy. Let me go back to this. There are three ways to measure life expectancy. The quickest and dirtiest is just how long people who are born now can be expected to live. And that's generated by looking at the death rates for different age groups by decade and projecting that out into the future. That's a good way to monitor the health of a single country's population, but it's not a good basis for international comparison. So we'll talk about longevity, but if we want to compare countries, we need to talk about age-adjusted longevity, because some countries have an older population than others. Italy, for example, has an older population than the United States, and old people are at greater risk of dying. And therefore, if you want to compare the health of Italians to the health of Americans, you've got to compare equal age populations. And that's done by comparing the longevity in each country to the average age in each country. So age-adjusted longevity is more accurate for international comparison than simple longevity. And then the most in-depth way to look at the health of a population and compare populations is healthy life expectancy. And that's what's on this first slide. Canadians' healthy life expectancy is 5.9 years longer. That means how many years does the average citizen live in good health? And it's prorated for years of chronic disease based on the quality of life. So if somebody had renal failure, was healthy until they were 80 years old, developed renal failure, and that compromised the quality of their life by 50%, then died at age 86 after 6 years of compromised health, their healthy life expectancy would be 83. So that's the most nuanced way to compare the health of one population to another. And we're going to look at all three ways. So first, we're going to look at age-adjusted life expectancy or more age-adjusted mortality rates. So this first chart looks at age-adjusted mortality rates. Let me get a better pointer. This first chart looks at age-adjusted mortality rates in the United States compared to 21 other wealthy nations. And based on the difference in the mortality rates, it calculates how many excess deaths there are in the United States or how many fewer deaths than predicted there are in the United States. So in this chart, we're looking around the 80s, and I look at 1982 because that's when I went into practice, and what the situation was when I went into practice. And what we see here is that in 1982, if you compare the age-adjusted mortality rates in the United States to those in other wealthy countries, you see that 50,000 fewer Americans died each year than would be predicted by the mortality rates in the other countries. So that's a good thing. And the reason why I titled this lecture, Make American Healthcare Good Again instead of Great Again, is that's good. It's not great, but it's good. 50,000 fewer American deaths. But watch what happens as time goes on. We see that comparative death rate get higher and higher compared to the other wealthy countries. I mean, relentlessly higher and higher, starting after that period in the early 80s. So that by the time we get to 2019, this is pre-COVID, so the data are not confounded or influenced by COVID. We see that there are 622,000 excess deaths in the United States every year compared to the other wealthy countries. Now, that's an enormous problem, 622,000 people. Now, if we keep going, COVID, when we get into COVID in 2020 and 2021, then we get a real stress test on the American healthcare system. And we find that the excess deaths, this is not the absolute number of deaths in the United States, these are the deaths that are greater than the average of the deaths in the other countries, which were also dealing with COVID. But our excess deaths shoot up during COVID and hit in 2021, they hit 1.1 million excess American deaths each year. Now, to put that number in perspective, the 9/11 terrorist attack on our buildings in New York killed 3,000 Americans. And it changed world history. It changed the United States relationship to the other countries. We invaded Iraq. We changed our society based on the death of 3,000 people on that single day on 9/11/2001. And now we've got 1.1 million excess deaths per year, which is 3,000 excess deaths per day. Per day, every day. When a plane goes down and 60 people die, and it's a tragedy, and it deserves to command the news cycle, and it does. And we stay on each plane crash until something else comes along. But what 60 people dying in one day in a plane crash? We're talking about 3,000 Americans dying every day in excess of the predicted mortality rate based on our age-adjusted population. It's unthinkable how inferior Americans' health is to the people in the other countries. And if we switch perspective now, because I don't want you to think that I'm sort of biasing these statistics by choosing age-adjusted mortality or longevity or healthy life expectancy. So if we look at in 2000, we compare the healthy life expectancy in 12 wealthy nations, including the United States. And our healthy life expectancy, this is the median of the other countries. The median would be 68.1 years of living in good health. It's the median in the other 11 countries. The United States isn't there because we are 60, our healthy life expectancy in 2000 was 65.3 years. So Americans were living 2.8 years less than the median of the other wealthy countries in 2000. And our healthy life expectancy ranked 38th in the world. Now, we've gone from pretty good in the early 80s. We're a little better than average. Now we're losing ground, and the Americans' health is getting worse, not better. In fact, if we look at how the years of healthy life expectancy changed between 2000 and 2021, we see in these other 11 countries that they all improved in healthy life expectancy, and they went up, I don't know, 1.5, 1.8 years average, something like that. But if we look at the United States healthy life expectancy actually went down between 2000 and 2021. It went down. We lost 1.4 years of good health, while all the other wealthy countries went up. And our ranking in the world went from 38th in healthy life expectancy in 2000 to 67th in 2021. Now, this is a disaster. A disaster. And I'm going to show you most of the rest of the lecture is going to be about how this situation can be going on and not be covered by the news and not be mentioned by doctors all the time that we're working in an inferior system. And we've become used to it. And we think that because we have access to the latest technology, which we do, we think that we're getting the best health, but we don't. And that's where the cultural meme of good health comes from advanced technology fails in the United States. So this is here's a portrayal of our loss falling further and further behind other countries in life expectancy at birth. And you can see back here in 82, we're pretty close. And these curves relentlessly separate as time goes on. And something that's particularly notable is that after 2014, longevity within the United States, now that's a fair comparison because our age distribution didn't change very much within the United States. So we look at 2014 and we see our longevity has actually gone down since 2014. And it was going down slightly even before COVID hit. Now, this is really critically important because there was a huge natural experiment in 2014. Obamacare came in, and Obamacare led to about half of the uninsured Americans getting health care coverage. This has been a major issue. The United States is the only country that doesn't have universal health care, and it's sinful, and I agree it's sinful. That I believe that health care is a right, and it's a matter of justice to make sure that all Americans have access to health care. And we would think intuitively that exercising that right or implementing that right widely in society would lead to better health. But in fact, we were spending more money on health care, but we weren't getting better health. And to put this in context, for the most part, the Democrats have worked on expanding healthcare and improving healthcare justice so that social and socioeconomic barriers or racial barriers or country of origin barriers didn't prevent people from having access to healthcare, and that's a national commitment, or should be a national commitment in the view of most Democrats. But because of the way our country works, and I'll be talking a little bit about more about this when we get on, in order to achieve that greater coverage, the politicians had to work out an agreement that was acceptable to the commercial interests. And that's what defined Obamacare. And that's why we didn't get a public option, because the commercial interests didn't want a public option to compete with commercial insurance. So doing it the liberal way, meaning let the market work, but let's have some principles and expand healthcare coverage to as many of the uninsured Americans as we can. It didn't work in terms of making people healthier. We're going to talk about why it didn't work. Now, sometimes at this point in the lecture, people will say or think, yeah, that's, but that's about poor people. That's not about us. We're educated. Most of us went to college, and we know how to take care of ourselves. So it's too bad about the poor people having bad health, but that's not really directly affecting me and my family. That is not true. As we see in this slide, this is a study comparing health outcomes of privileged U.S. citizens with those of average residents of other developed countries. So we're going to compare wealthy white Americans who live in the 1% and 5% highest income groups in the United States, and we're going to compare that privileged group to average Americans and to the average citizens of the other wealthy countries. And what we find is, in this comparative effectiveness study of 6 health outcomes, white U.S. citizens in the 1% and 5% highest income counties obtain better health outcomes than average U.S. citizens. So wealthy people in the United States do better than average people in the United States. But, and this is an incredibly important but, they have worse outcomes for infant mortality. This is the white citizens who live in the 1% and 5% wealthiest counties had worse outcomes for infant and maternal mortality, colon cancer, childhood acute lymphocytic leukemia, and acute myocardial infarction compared with the average citizens of the other developed countries. Average citizens. So we're spending much on our health care as the citizens in the other countries. But the health of the wealthiest, most privileged Americans is inferior to the health of average citizens in the other wealthy countries. Now we get to the financial part of it. So this is health expenditure as a percentage of GDP, 1970 to 2022. And you can see back in 1982, when we were a little bit better than the other countries and 50,000 fewer Americans died than would be predicted by the age-adjusted mortality rate, we were spending a little bit more than the other countries. This is our percentage of national GDP that we're spending, and this is the percentage of GDP that the average comparable countries are spending. So in 1982, we're pretty close, and look how these lines separate relentlessly, just like the separation of longevity and healthy life expectancy. So as we're losing ground in terms of the health and longevity of Americans, we're spending more and more money to achieve those inferior results. So in 1980, we were spending 1.6% of our GDP more than the other countries. And by the time we got to 2002, it was 5.4% more. And actually in 2003, our healthcare spending went up 1%. So it's 6.4%. And that translates into approximately $1.9 trillion in excess spending each year. So that's the excess, that's an excess. That is more than the budget deficit. So all that we hear about the budget deficit, we can't live with the budget deficit, it's going to create increasing debt on our children, and it's going to cause inflation and high interest rates and so forth. All of that, we could balance our budget if we spent what the other countries spend. But we've got to be careful, and this is going to be how I'm going to finish the lecture. We've got to be careful because that expenditure can't be cut with a machete or a chainsaw. It can't be cut that way. It's got to be cut with a scalpel skillfully so that we get to the roots of the reason why we've developed this situation since 1980, where we're spending so much more and having so much worse health. So high health costs, low health for the American people. Let's look at how the American healthcare system compares to other countries. And we're looking at when we look at um, higher health system performance, we're looking at variables such as outcomes, cost, equity, access, and access. And I think this is maybe 10 other wealthy countries. Yeah. So here we have high health performance and lower health performance. And here we have lower healthcare spending and higher healthcare spending. And you can see that these countries all group pretty close together. But the United States isn't in this graph because that's where we are. By far the lowest health system performance and the highest healthcare costs. It's a disastrous system. And Nobel laureate Angus Deaton looked at this. He's the one who coined the phrase diseases of despair and talked about the higher death rates in white Americans without a college education. He looked at these facts that I'm showing you now, and he concluded, and listen to this powerful language, he concluded American healthcare does a poor job of delivering health, and then those are the statistics we just looked at, but is exquisitely designed as an inequality machine, commanding an ever larger share of GDP and funneling resources to the top of the income distribution. So Dayton, Nobel laureate, professor of economics at Princeton, is saying he's looking at this data that we're spending twice as much as the other countries, in excess $2 trillion, that the health of Americans is plummeting from 38th in the world in 2000 to 67th in 2001. And he's saying the problem here is that the job of the healthcare system only appears to be to make people healthy. It's really to maximize the profit that healthcare generates. So it's profit-driven healthcare, not health-driven healthcare. And as we'll see, the currency of this market, which we hardworking doctors believe to be true, and you you concerned, intelligent consumers want to learn about, and I thank you for coming and listening to this lecture. You want to learn about that the purpose of this system is not to make us healthier. It's to make more money for the investors. So if we take a step back and let's ask what ought to be the primary goal of healthcare instead of maximizing the capital return on investment, what ought to be the primary goal? And in my mind, it's a simple answer. And if any of you have any upgrades, let me know in the discussion period. But I think the function of our healthcare system ought to be to maintain and improve individual and population health most effectively and efficiently. And in order to do that, we rely on medical science. And we assume that medical science is objective, but it's not. Medical science is socially embedded and it is subject to the forces that influence our society overall. It's not, it does not give primacy to objective and epidemiologically based data. It does not do that, which raises these two questions. Why are we failing so miserably to achieve this goal? And why are smart and committed doctors and other healthcare professionals willing to go along with this crazy system that's so dysfunctional? And that's what we're going to turn to now. And the first thing we need to look at is the process of commercial capture of what's taken as medical knowledge. I put quotes around knowledge because knowledge can mean two different things. Knowledge can mean what doctors, highly educated doctors, accept what evidence they require to accept so-called scientific findings as true, and as true enough to make patient care decisions based on this information. So what are the criteria that doctors require to consider that they know a new fact about medicine, healthcare, optimal care? That's one kind of knowledge. The other kind of knowledge is what's true. And the gap between what doctors are taught to take for truth and what's actually true is shockingly, shockingly enormous. And that's what we're going to talk about. So this whole thing started, I remember the graphs that I showed you before about the relative health of Americans, that 50,000 fewer Americans were dying in 1982 than expected based on comparative age-adjusted health life expectancy in 1982. And now we've got 1.1 million excess American deaths based on that. And the amount that we spend went from 1.6% of our GDP up to 6.4%, greater than the other countries. All this started at around 1980, early 80s. And that's when American healthcare was good. Not great, but good. But things have gone straight downhill since then. And one of the major changes, it was not particularly visible, but one of the major changes was the way that science is funded back in 1980. It's going to be changed again as these huge cuts to NIH are going to be implemented. But let's stay focused from 1980 to 2024. So in 1980, grants from the National Institutes of Health and the National Science Foundation became fewer in number and harder to get. For universities to turn to alternative sources of research support not only became prudent, is not only prudent, but downright essential. Now, this is from an article called The Academic Industrial Complex. You can see the references, all the references are in the bottom left-hand side of the slides. And if you want to check them, please do. But what happened in the early 80s is that the NIH funding for researchers in nonprofit institutions like universities and research centers went down just as managed care was starting to come in. And managed care, now that the cycle has played out over the last 40 years, managed care hasn't done too much to manage care and improve the quality of care. But one thing that managed care did very well is it created a contracting situation where the insurers could use the volume of patients they controlled to negotiate lower prices from the hospitals for care. So hospitals that were research centers, but were living on the fat of because their contracting wasn't disciplined by large groups of buyers of healthcare services. But as the managed care came in and put that discipline in and controlled their prices from very high prices, brought them down. If the hospitals wanted to have access to those patients, they had to make a deal with the insurers. That cut out a lot of fat in the system. So just as this fat was getting cut out, the NIH was cutting down its funding of grants. So when I was in medical school in the 70s, it was, in my opinion, shameful when I heard that a professor was taking money from a drug company to do research. That didn't seem right. It seemed like a total conflict of interest. That was in the early 70s, but that flipped completely. So that the article in the journal Science, Academic Industrial Complex, was written in 1982, published in 1982. And this article says scientists who 10 years ago would have snubbed their academic noses at industrial money, and 72 is when I went into medical school, now eagerly seek it out. And this is a critical change in where the rubber hits the road in American healthcare and patient care. So instead of being sort of having a sort of a cringeworthy feel about professors working with drug companies, it suddenly became not just a source of income for the professors, but it became actually a source of prestige because they could be part of these big clinical trials that make a splash in the journals. And it was good for their careers to be partnering with the commercial interests. But it took away the academic freedom that they had prior to being dependent on the drug companies for their funding. And we had a second thing. So the first thing that changed is the decrease in the funding from NIH and the decrease in reimbursement from managed care. The second thing that happened is the Bayh-Dole Act. In the late 70s, the Japanese were picking our pocket. Japanese cars were a rarity in the early 70s. And suddenly Japanese cars started to play a major role in the American automobile industry. What was happening by the United States is telling of the story was that Japan had an industrial policy where the government was supporting private industry in their development of products and their efficiency and quality. The government was playing a role in that was not being played in the United States by the government. And that gave Japan a leg up as Japanese autos came in to compete with American autos. So in order to change that and make Americans more competitive and make the research that Americans do get into the marketplace faster, the Bayh-Dole Act said that when a research institution or researchers are funded by federal money and develop patents that have value for products that can be brought into the marketplace, the institutions and the researchers themselves can keep the profit. And the goal of this was to motivate research institutions and researchers to do science that would be effective in the marketplace and to get it into the marketplace by offering the researchers the profits, even though the federal government had paid for the research. So that's the Bayh-Dole Act. And the president of Harvard was Derek Bok at the time. And he wrote in an article in Harvard Magazine in 1981, Harvard University President Derek Bok described universities' reliance on industry funding. This is the shift we're talking about to private funding. He described universities' reliance on industry funding for research as causing, quote, and listen to this poetic language, an uneasy sense that programs to exploit technological development, especially medical programs, are likely to confuse the university's central commitment to the pursuit of knowledge. And I would add, and I think he would allow me to add, though I don't know that, not just to confuse the university's central commitment to the pursuit of knowledge, but to the pursuit of knowledge that will further our cultural value of bringing better health and a higher quality of life to all Americans. That was the purpose of universities. And they got transformed into research institutions that would first and foremost generate profits for the researchers themselves and especially for the drug industry and the other biotech industries. And President Bok's fears certainly were borne out. So now we look at this changed environment of medical research, and we ask two fundamental questions about our research. One is the new medical knowledge that informs healthcare professionals and policymakers epidemiologically balanced? In other words, is it prioritized to have the medical interventions that are going to be most effective at making Americans healthier? And not to make more money, but is it going to make the American population healthier? And if we look at a beautiful paper that looked at the anatomy of medical research, answers precisely that question. So this is from 2014, and it looked at how American research funding is allocated. And what they found was that the United States spends $16 billion a year annually on research directed at new drugs and medical devices, but only $5 billion aimed at health services research, which examines access to care, quality of care, and cost of care, and the health and well-being of individuals, communities, and populations. So these are exactly the things that we looked at before, that where we compared the function of the American healthcare system to the function of the other healthcare systems. These are exactly the metrics that were chosen to make those comparisons. And only 4% of our research dollars were committed to addressing those fundamental aspects of the quality of function of research of healthcare systems. Only 4%, and 96% was spent on developing new drugs and devices. So why the disparity in investment? My hunch is that you all understand what happened. One major difference is that new drugs and devices command favorable prices, and their value accrues directly to the firm that invests in them. In other words, our system, the currency of our healthcare system, is not the production of health, it's the production of money. And this system has been taken over by the commercial interests, and they've been able to mask the fundamental purpose of maximizing their profits. They've been able to mask that in the cloak of objective science and the serving the public good, but they didn't, and we're going to keep looking at that. So one major difference is that new drugs and devices command favorable prices, and it is in fact drugs and devices that are the most rapidly rising costs in our healthcare system. And yet we're not investing in the innovations that will decrease morbidity and mortality. So we have the market for medical research is driven by financial values, not health values. And I'm not anti-capitalist, and I think people are motivated by the opportunity to make money, but we need guardrails on this capitalism so that that activity, financially motivated activity, can go forward and is accelerated by a process that will serve Americans' interests. And we got way lopsided on the seesaw towards serving the financial interests. In fact, instead of 96% of our health being determined by the drugs and devices we get, a very small percentage of our health is decided by that. Now, I'm not saying medical progress isn't good. Saved my life. I would have been dead 3 years ago, due to a complex cardiac arrhythmia that was fixed. So I am very grateful for technological advances, hugely grateful. But we don't have to spend that much, and we don't have to sacrifice population health to have technology developed that helps a few people, not the vast majority of people. So if we look at the components of population health, if our job really is to make Americans healthier most effectively and efficiently while preserving their freedom, that's population health would be our target, not the 96% of the research that we're doing that goes to drugs and devices. And we find that in terms of the determinants of population health, 20% of healthcare, of 20% of population health is attributed to the quality of healthcare. And very small part of that is attributed to new developments in healthcare. Basic healthcare does very well for most things, not all things, but most things. So 20% of our health is determined by healthcare. 30% of our health is determined by health behaviors like tobacco use and alcohol use, unsafe sex, diet, and exercise issues. 40% of our health is determined by socioeconomic factors. And in the United States in particular, we don't consider the public's living situation or public's employment opportunities or the safety of the communities we live in. We don't consider that as a medical factor that needs to be addressed concurrently with the kinds of things that we think of as good medical care. But we do need to do that. And as you'll see in the next slide, we are outliers in the extent to which we ignore the social factors that contribute to health. And then 10% of our health is determined by our physical environment, air quality, the built environment, sidewalks, and so forth. Now, don't get scared by this slide. It looks very complicated, and I'll take you through it, and you'll see that it's quite simple. These bars, these countries are wealthy OECD countries, Organization of Economic Cooperation and Development countries. And what we're looking at is the total percentage that of GDP, national GDP, that each of these countries spends on combined health services and social services, and then how that breaks out in each country between spending on health services and social services. And it's by getting into the guts of this data that we see the difference between the United States and the other countries. So let me get some water. So we see here in red the OECD average amount that's spent on combined health services and social services is 26%. And we see that the spending on health services is 9.4% of GDP, and the spending on social services is almost twice that much at 16.9%, and that adds up to 26.3%. And if we look at the United States, what we see is that we spend a little bit more than average on the combined health services and social services than the average OECD country, 3% more of our GDP. But the ratio of spending on health services to social services is reversed in the United States from where it is in the other countries. So the average ratio of social service to healthcare expenditures for OECD countries is 1.8%. These average countries are spending 1.8 times, not percent, 1.8. So these countries are spending 1.8 times more on social services than they are on health services. But in the United States, that ratio is reversed, so that we're spending way more on medical services than social services. And we're spending less than half as much in the United States on social services as medical services. And now this is where it gets very interesting. The ratio of social to health services expenditures, the ratio, not the absolute amount of spending, but the ratio of social spending to health spending was significantly associated with greater life expectancy, lower infant mortality, and fewer potential years of life lost, longevity. So what we're seeing is it's not just the absolute amount that's spent on social services and healthcare services, but the higher the ratio of social to health spending, the better the health in the population. And the authors of this article concluded, and this is extremely important in understanding this, and this fact is quite well covered up by all the news, the daily bombardment of news about biotechnology breakthroughs and all the drug ads on TV and so forth. Our findings suggest that the paradox of high health spending without improved health outcomes within the OECD countries may be informed by differences in spending in social service areas. Reforms that target only health expenditures may miss important opportunities. And this is a subtle way of saying that the United States is a grotesque outlier in this, and that we need to address the social side of healthcare. We certainly need good research, and we want to make progress in diseases that and that don't affect as many people as other diseases. But we want to address the social factors because that's the primary determinant of population health. So the first question is the knowledge that informs healthcare professionals and policymakers epidemiologically balanced? The answer is no. It's balanced to generate the highest return on investment for the companies, the investors, and the executives in the healthcare industries, especially the drug and device industries. It's not epidemiologically balanced. It's balanced in a purely economic, financial way. It's balanced to maximize financial return, not health return. Nonetheless, science we think is objective. And even though it's being paid for by commercial interests, science is objective, it's peer reviewed, and we assume that we can trust the mechanism that our system of generating new knowledge uses. But we need to ask the question and look at that. Is the knowledge, and again, I'm in quotes because we don't know, it's ambiguous about whether knowledge means what's true or knowledge means what's believed based on the criteria that doctors and policymakers and the public have been taught to believe is true. So is the knowledge reasonably accurate and complete? And now, as shocking as the previous data was about the comparative performance and cost of our American healthcare, this, I think, is really, really far more disturbing in my mind, how what is taken for knowledge and what directs our healthcare has been so captured by commercial interests. So this is before we get into that. In 1991, 81% of medical research, was done by universities and nonprofit centers. They controlled the research, they largely designed the research, they owned the data, they analyzed the data, and they published the results of that, 81% in 1991. But by the time we get to 94, we're talking about the privatization of research, which along with that went the private control of research. So 81% in 1991. By 1994, the 81% of research that was done by universities and nonprofit organizations had gone down to 63%. And the difference had gone to almost entirely to for-profit research companies that the drug companies hire directly to do their research. So the drug companies can have control of the design of the research, and they have control of the data, and they have control of the publication of the results. And we'll look at studies about that in a sec. But 1991, 81%, it goes down to 63% of research is done in nonprofit institutions. In 1994, it goes down to 55%. In here, this dropping percentage motivated Drummond Rennie, who was the deputy editor of the Journal of the American Medical Association somewhere in the mid to late 90s, to say that this situation of taking research out of nonprofit institutions and delivering it to for-profit companies who work directly for the funders, for the drug companies and the device companies, that because the percentage of research that's being done in the universities and nonprofits was going down, that the universities had to compete with the terms that the private research contract organizations were willing to accept to get the contracts from the drug companies. And that led to what he called a race to the ethical bottom in our medical research in the United States, a race to the ethical bottom. These are pretty harsh words, and JAMA is not some radical rag. It's the Journal of the American Medical Association. And this transfer of the research funding continued to decline. The transfer to private industry from nonprofits to continue to decline. So this change was so rapid. In 1991, 81% of that research was And it went all the way down to 26% in 2004. That's just 13 years later. This is a revolution in the control of our medical research. It didn't get any headlines. I only understood this when I started to understand this when I left practice in 2002 to write my first book, because it was so obvious to me as a primary care doc and as somebody who had done a research fellowship after my residency training, and I understood statistics and epidemiology. It was clear to me that the journals were being captured by the drug companies. And that's why I left practice in 2002 to dive full time. And it's turned into sort of a 24/7 life passion for the last 25 years. So now we get to 2004, only 26% of the research is being done in universities. The rest is for-profit research institutions. And the universities have to compete with the terms that the private research companies are offering the drug companies. So this is a brilliant study that the title is Restrictions in Pharma Academic Medical Center Clinical Trial Agreements. This study looks at the terms upon which university and research organizations researching the contracting offices of the nonprofit institutions. It's the terms that the contracting offices agree to when they take the private money to do research in a university or nonprofit research center. These are the terms of the research. So the survey asked data ownership. In your best judgment, asking the research office contractors, in your best judgment, would your office allow a clause in a multi-center clinical trial agreements, saying that the sponsor will own the data produced by the research? Sponsor owns and controls the data, determines who can see and who can't see the data. And 80% of universities and research centers said that they would allow a contract that allowed the funder to own the data. Now, down here, would you allow the sponsor to include its own statistical analyses in manuscripts? So the sponsor, the drug company or device company, has sponsored the research, and it's involved university researchers, because we're talking about contracts with universities and research centers. But this question is, would you allow the funder to put its statistical analyses in the manuscript instead of the actual researcher's analyses? And 24% of the research contracts allowed the funders of the research, the commercial funders, to put their statistical analyses in. And this one is the most mind-boggling of all for me. The office will allow the sponsor, the commercial company, will write up the results for publication, and the investigators may review the manuscript and suggest revisions. To translate this into plain English, this is saying how many of those contracts will allow the corporation that funded the research to ghostwrite the articles that are sent into medical journals, allow the companies to ghostwrite the articles, and the researchers who did the research, ostensibly did the research, are only allowed to suggest revisions. They cannot insist on revisions, and their only recourse, if their suggestions are not accepted, is to resign from the project. If they resign from the project, they lose their research contract, they lose a lot of prestige, and they're going to lose their ability to get more research contracts. So 50% of the research that's done in academic medical centers and universities allows that research to be ghostwritten. Those are the terms upon which the universities that the universities accept in order to maintain their 26% of research funding. Now, you might assume that there were guardrails on the extent of commercial influence and distortion of this so-called knowledge that's being generated by universities and research institutes. But that is not the case. And when I left practice in 2002, because in my opinion, the journals were being taken over by the drug companies. Um, uh, when I Let me get this back. When I left practice, it was because of that takeover. And it was a drug called Vioxx, which was an arthritis drug that was no more effective, but was supposedly safer because it caused less stomach upset. And I got into the FDA data that was presented to the advisory committee to review Vioxx and update the label. And it was very clear. I had done the research fellowship 20 years before. It was very clear to me that the data that Merck had sent to the FDA about Vioxx showed that it was no more effective at relieving arthritis pain than over-the-counter anti-inflammatory drugs like Advil or naproxen. So no more effective, but that it was a significantly more dangerous drug. It wasn't a safer drug, it was more dangerous. And that caused me to leave practice and say, look, I'm taking care of one patient at a time, but this isn't working because our system, the information that directs our system has been taken over by commercial interests, and they're not playing by the rules. So I wrote that book. It took me 3 years. A week after my first book, Overdosed America, was published, Vioxx was pulled from the market. A second study had shown what the first study that I had analyzed and come up with my conclusion that it was a dangerous drug had confirmed that it was a dangerous drug. And suddenly I was on the Today Show and got called whenever a drug got in trouble. Did maybe 100 national TV shows. And in the process of becoming a public figure, lawyers saw me explaining these things, and they thought I could speak English fairly well. I don't mean that as as I don't mean that as a jingoistic statement. I mean it as explaining scientific concepts to the public. And they asked me to participate in litigation, which I started to do, and I soon became full-time expert in national litigation. And in that litigation, I got to actually see the hard drives of the drug companies, to see what their research development process was, to see how they carried out their research, to see the analyses of the research, to see the communications that went on between the marketing people and the executives, and all the things that you say to yourself, geez, I wish I could had access to what the drug companies really know about this drug or that drug. I had it. And I learned a whole lot that you can't learn. Doctors, please don't blame doctors for not knowing the things that I'm telling you now, because you can't see it. It's invisible unless you get into litigation and you have access to the corporate documents. So this is one such document that came out of litigation. Now, this is not litigation I was in. This was about an antidepressant made by Pfizer. But this slide was presented in court for that litigation about the antidepressant. And this is a slide from Pfizer. And this makes you think of Maya Angelou's wisdom. When someone shows you who they are, believe them the first time. And this is Pfizer showing us who they are. This is a slide that describes Pfizer's view of data ownership and transfer. And this is actually Pfizer property now. It was shown in court, which is why I can show it to you. So data ownership and transfer. Pfizer-sponsored studies belong to Pfizer, not to any individual. And that's what the research contracts that I showed you say. And then this, look at this, the purpose of data. One might think the purpose of data is to help doctors provide better, more effective and efficient healthcare to their patients. But no, that's not Pfizer's purpose for healthcare. And that's where the truth lay. The purpose of data is to support directly or indirectly marketing of our product. It's a marketing process. They want to enhance their labels, and that's fine if they find new uses for drugs that are already on the market. But they're going to produce those articles so that they can have the articles published and they can buy the reprints from the journals, and then their drug reps will hand out these articles from the doctors will think they're getting the latest in scientific evidence, and they'll adopt those findings. And the bottom line is, therefore, commercial marketing and medical, and let me translate that. That means the marketing department of the drug company needs to be involved in all data dissemination efforts. The marketing part of the drug company needs to be involved in all aspects of data dissemination. Now, let me show you how this plays out in the real world. This is real data from the drug Paxlovid. And as you know, Paxlovid is recommended for COVID to minimize the risk of serious disease in people who have had COVID symptoms for less than 5 days. And when Paxlovid was first seeking FDA approval, emergency use approval, they did a study called EPIC-HR, high risk patients. And this study included patients who were unvaccinated and had no antibody evidence of having had COVID. And they gave them Paxlovid. They gave half of them Paxlovid in the first 5 days of symptoms, and they gave half of them a placebo in the first 5 days of symptoms. And they found a remarkable 90% decrease in the incidence of serious illness and death in the people who took Paxlovid. But this was a high-risk population. They also very responsibly did a standard risk population in people who were vaccinated and did have evidence of COVID. And now about 98% of Americans have either been vaccinated or have antibody evidence of COVID. And they started this second study only a month after the first study. And the first study was finished in May of 2022. The second study was finished 3 months later. The second study showed that there was not a benefit in giving Paxlovid to people who were either vaccinated or had previous infection, like 98% of Americans. That did not produce a significant reduction in the risk of serious disease or in the risk or in the duration of symptoms. The duration of symptoms went simply from 14.1 days in the people who got the control drug, the placebo, and it was 13.8 days of symptoms in the people who got the Paxlovid. So here they have done a study, which is fine, a high-risk study, and then they do the standard risk study, which now applies to 98% of Americans. The high-risk study was published in February of 2022. And the standard risk study, which showed no effect for the 98% of Americans who have antibodies or are vaccinated, was published 26 months later. So for that 26 months, doctors were told that the scientific evidence showed that Paxlovid was going to be effective for their patients. When Pfizer was sitting on this data with no reason not to publish it except financial reasons, sitting on this data, and it wasn't part of evidence-based medicine, that Paxlovid was not effective. And now if you talk to your friends or your doctors, they'll say, oh, it's effective, and people will say it helps me. But people think it helps them because most people who get COVID get better, and they get better whether they take Paxlovid or not. So this is an example of how what doctors believe is the scientific evidence can be manipulated by a drug company that owns the data. So really what we've got is a doctor who's in this, he's looking for scientific evidence, and his or her rowboat is called scientific evidence, and there's a medical bag in the back in case the doctor needs to make a house call while he or she is out in a rowboat, and they're looking at the information that's above the waterline. So they're seeing peer-reviewed journal articles, clinical practice guidelines, drug company marketing, and here's all the journals, this is public information that we get, and that's what they can see. And that's what they think is the reality of the scientific evidence. But it is not even close to the scientific evidence. This is the scientific evidence. Each study, each patient visit in a study generates a piece of paper that has all the data, the blood pressure and the blood sugar and the symptoms and the side effects and so forth. And each piece of paper, this enormous amount of data gets turned into electronic data sets. The electronic data sets get tabulated into what's called clinical study reports. Those clinical study reports, all of this remains underwater and generally cannot be accessed without litigation going on, without a subpoena for discovery. The doc can't see that. The doc has been trained to think that scientific evidence is what he or she can see above the waterline in this iceberg. But this is where the real information lies. Now, these clinical study reports are 2,000 or 3,000 pages long. I learned how to get through them pretty quickly. In 10 or 20 hours, you can get a sense of what the study was about and whether the research process followed the protocol that was identified. And let me tell you an anecdote, because the journals, when they get a manuscript submitted, they just get a 10 or 20 page manuscript that's a summary of the data from the clinical trial, generally written with the assistance of writers who are hired by the drug company and generally run through the marketing departments of the drug companies, as we said before. And these are the manuscripts that are sent to the journals end up here. These clinical study reports that contain about 80 or 90% of the real truth that's buried in here, the clinical study reports are done, but they're not, the journals don't require them to be submitted with the manuscripts. So when the manuscripts are submitted for peer review, the peer reviewers and the medical journal editors don't get to see the real data from the study. They just get to see the 10 or 20 page manuscript with the data that the drug company approved putting in the article. So when we talk about peer review being the gold standard of scientific evidence, peer reviewers do not get to see the data. And the doctors don't understand that when they read the article in the journal, the peer reviewers have not had and do not have access to an independent statistical analysis of the real data. So I was at a meeting at Harvard. I was on the faculty of the department. I was a lecturer in the Department of Healthcare Policy at Harvard Medical School for 15 years. And I was leaving a meeting and becoming increasingly aware of these matters. And I was walking out with the deputy editor of a very prestigious journal out of the room that we were meeting in. And I asked the editor why didn't they simply require the drug companies who funded clinical trials to submit these clinical study reports along with the manuscripts that they submit to the journal so that the journal could at least have this 80 or 90% check on the accuracy of the manuscript as representing the data accurately and completely. It's a simple matter, and people can learn how to go through these very quickly. And in an ideal situation, manuscripts that are submitted to journals would go through a statistical analysis with a statistician who had access to all the data before it went to a peer reviewer. But that's not what happens. So I asked him, why don't you just simply require these study reports be submitted? They're already prepared. Every clinical trial has a clinical study report prepared. Why don't you just require that it be submitted with the manuscript that's coming in? And that editor said to me, before I could take the next step out of the room, he said that would be a death spiral for the journal. And you go, whoa, wait a minute. What he's saying in that simple statement, a death spiral, is that if we require transparency of peer review, then the big drug companies aren't going to send us their manuscripts to publish because they're going to be able to verify. They're going to require that they verify everything that's in the article. And if we do that, then we won't get those manuscripts and our impact factor will go down. And in fact, that experiment was done. The Journal of the American Medical Association for several years did require statistical analysis of manuscripts that were sent in a good way before the peer reviewers got it. And what they found was that they lost a significant number of the big clinical trials. Now, why does it matter to the journals that they lose the big clinical trials, that they go to other journals? This is a key fact that is not very poorly known, that much of the medical journal's incomes, and the more prestigious a journal, the higher the percentage of their income, is derived from the journal selling reprints of the articles they publish back to the drug company so they can give those articles to their drug reps. The drug reps hand them to the doctors, and the doctors think they're getting scientific evidence. So there's a complete conflict of interest. This is not an arm's length deal. The journals are in the deal. They want the big clinical trials to maintain their impact factor, and they want it in the early 2000s, I think 2005. Lancet released data that showed that 41% of its income came from 41% of its income came from selling reprints back to the drug company that sponsored the article. So this is a stable system, but it's a system that is not serving the public. And in fact, this is, y'all probably heard of Plato's allegory of the prisoners in the cave, and the prisoners are chained here, and they're looking at images that are cast on the wall. There's light from this fire, and these Greek folks are holding up images of a horse and a soldier and so forth. And the prisoners are trapped looking at these images and thinking that they're seeing reality. Now let's take these poor prisoners and let's think of them as doctors who are looking at the evidence-based medicine that's published in medical journals, thinking that they're seeing the truth, but they're just seeing a shadow that's cast from the source of that information. And that's the position that doctors are now in. This leaves us with a situation where doctors think they're getting evidence-based medicine, but if you look at the journal publications, only 23% of important patient outcomes are published in each article. Only 19% of the benefit outcomes are published, and only 26% of the harm outcomes are published. Now, there was a movement to increase transparency in peer review. What I'm telling you now had gained some momentum in 2015-16. Word got out. It was starting to be an issue that the journals had to deal with. They said they were going to study it for a couple of years. And then this article appeared in the news source Stat, the medical news source Stat, in June 2017. After more than a year of deliberation, editors, the ICMJE are the editors they're talking about. And that's the International Committee of Medical Journal Editors. And they act as a group to make policy for medical journals. And after more than a year of deliberation, the editors of some of the world's leading biomedical journals have come up with a declaration on data sharing destined to usher in a glorious world of transparency and rigor in science. Now, wouldn't that be a wonderful headline for an article? And then the article goes on and says, no, scratch that, sorry. They've come up with a policy with a couple of weak sticks and no carrots. And what their policy is, this is hard to believe, but an article that came to my attention about an anti-Alzheimer's drug in the New England Journal a couple of years ago, Leqembi, claimed that Leqembi was significantly more effective than a placebo in slowing down the progress of Alzheimer's disease in early Alzheimer's patients. In fact, the difference was only about a quarter of a meaningful clinical difference, even though the research was designed to create statistically significant findings. So the drug companies control this, and they designed a study in which a statistically significant benefit didn't translate into a clinically significant benefit, but they published the article anyway. That caught my attention, as you might imagine. So I went into the bowels of the New England Journal's data about the article, and they did report the requirement is that the drug company has to declare its intention for data sharing on each article. So I went in to see what their data sharing agreement was, and their data sharing agreement was that they wouldn't share data. And the end. I mean, that's it. No data. So the problem here is that only about 1 out of 3 or 1 out of 5 new drugs is clinically superior, meaningfully superior to older drugs. The problem is that in the United States, docs don't have access to a health technology organization that will tell them, explain to them which drugs actually add benefit and which ones don't. And this wonderful study that was published in JAMA showed that they separated a group of, I think, 135 drugs, new drugs, into high added benefit and low added benefit. And what they found is that the drug companies spent 3 times more marketing their low added clinical benefit drugs. They spent 3 times more marketing the low efficacy drugs compared to the high efficacy drugs. And when they create marketing, they know what they're doing, they know how they spend their money, they spend it wisely, and they generate sales. So the low added clinical benefit drugs get 3 times more money in advertising. Let me show you how this plays out. This is an FDA approved drug label. You can get them on the web, you may get them with your prescriptions when you pick them up at the pharmacy. And this is an FDA approved label for Ubrelvy, which is a migraine drug that was approved in 2019, and it got on my radar screen because they've been advertising pretty heavily, and I like to look up the drugs that they're advertising to see what the truth is. So with Ubrelvy, this is the first page of the label, and the indications for usage are Ubrelvy is a calcitonin gene-related peptide receptor antagonist indicated for the acute treatment of migraine with or without aura. And it's not to be used for preventive treatment. It's only to be used when someone gets a headache. And we look at section 14. And if you try and do this on your own, I hope you will try and do this on your own, because in section 14 of a FDA label, you'll see the clinical trials that the FDA relied upon to approve this drug. And in this case, we see the clinical trial. There are 2 studies, and one is Ubrelvy 50 and 100 milligrams in study 1 against placebo, and study 2, 50 milligrams against placebo. And what you see here is that, let me go back 1 slide. What you see here is that 11.8% of people in the placebo group, or 14.3% of people in the placebo group, were pain-free at 2 hours, and 20% approximately of people who took Ubrelvy were pain-free in 2 hours. So if you look at this, you could make a claim that would be true, that twice as many people who took Ubrelvy got relief than who took the placebo and got relief. So the relative risk, the relative benefit is twice. And that's awfully good when you think about that, to double your risk of being pain-free in 2 hours. But it's not the relative risk benefit that counts. It's the absolute risk benefit that counts. And I will explain that. You see here that, let's do 100 milligrams because it's the more effective dose. You see here that 9.4% of patients, 9.4% more of patients, 9.4% of the patients in the study were pain-free at 2 hours compared to placebo. 9.4% and 7.4% in this study. So even though you can say correctly that twice as many people were pain-free at 2 hours, it's only 9.4% of people in the study. And when we translate that into number needed to treat, let's just round it up to say 10% of people, 1 out of 10% of people got better. 10% of people who took Ubrelvy 100 milligrams were pain-free compared to those in the placebo group. So if 1 out of 10 patients got better, it means you need to treat 10 patients in order for 1 to get better. Number needed to treat. So it's the absolute difference from the placebo. It's not the comparative difference. And the other statistics show the same thing. So 1 out of 10 gets better when they take Ubrelvy instead of a placebo. If we go to GoodRx, we see the price of Ubrelvy, 100 milligram tablets that we saw in the study, and you get 10, and they cost $1,000. Talk about $100 a pill. So, and only 1 out of 10 of the people who takes one of these $100 pills gets better, is pain-free compared to those who took a placebo. So that means you need to treat 10 people in order for 1 to get better. And for each headache that's relieved, it costs $1,000. Yeah, that could be a good thing or a bad thing. I'm not making a value judgment. I'm just stating a fact. Now, if we go to a older, tried and true migraine drug, Replax, which the generic name is elatriptan, we see that this is a different mechanism of action, which is important, and there is an advantage to Ubrelvy, which I'll talk about. But they say it's for the treatment of acute migraine, and people have to have a clear diagnosis, and it's not effective for prophylactic therapy. Now, if we go over to the warnings here, with the older, less expensive triptans, there is vasoconstriction. It does constrict muscles in your cerebral, in your brain, constricts vessels, and that's how it relieves migraine symptoms. So if a patient has evidence of cardiovascular disease or a history of cardiovascular disease, you wouldn't want to give them a triptan like Replex. You'd want to try Ubrelvy, even though it's far less effective. You'd want to try a drug that didn't have the risk of aggravating pre-existing cardiovascular disease. But that's a minority of people who take Ubrelvy, who take migraine medicines. And what we find is that Ubrelvy is not 10% better than the placebo. Ubrelvy is 30 to 40% better than the placebo. Excuse me, Replex, elatriptan is 30 to 40% better than placebo in the 40 milligram dose. So what you're doing is you're reducing the percentage of people who will have persistent pain is reduced by 30 to 40%. And the cost of elatriptan, instead of $100 a pill, we're talking $2.75 a pill. So 30 to 40% of people get better instead of 10%, and it costs $75 a pill instead of $100 a pill. So instead of costing $1,000 per headache that's relieved, it costs $10 per headache that's relieved. Now that's enormous, but when you see the Ubrelvy ads on TV, you wouldn't think that there was this difference in efficacy. So where are we? 86% of clinical trials are now commercially funded. 97% of the most frequently cited articles are commercially funded. Compared to non-industry sponsored studies, industry sponsored trials have significantly more favorable efficacy results, arm results, and overall conclusions. The majority of physicians continuing medical education is funded by industry, and 59% of the authors of expert guidelines have financial ties to an interested manufacturer. So we see that the information has been taken over by the drug industry, that the journals are complicit in this, and they make their money by publishing important articles and selling reprints back to the drug company, and that the guidelines are not based on access to the actual data. The people who write the guidelines only look at the composite of the articles that are funded, and they have been vetted by impotent peer review because there hasn't been transparency. Let's skip that. So how do we go forward in this morass of commercially controlled medical information? again, I want to repeat this. It's a sociology and knowledge issue. And it gets off in a whole other interesting line of inquiry. But we got to remember that the function of the production of this knowledge is to maximize financial returns on investment, not to maximize the health of the American people, and certainly not to do it efficiently. So if we want to achieve meaningful reform, number one, we've got to accept that farmers' role in society, primary role, is maximizing investors' financial return on investment. And one of the primary ways that that is accomplished is that the executives of the drug and device companies get a large part of their remuneration based on the value of the stock. So the executives and the chief scientists, they're all incentivized to produce so-called information, or air quotes knowledge, that will maximize financial return on investment. And Pharma's primary strategy to achieve that goal is controlling healthcare professionals' beliefs about their products. So what we have is a nexus of market failure that prevents accurate and complete reporting of scientific data, and prevents an epidemiologically balanced research agenda from getting to doctors who could then practice the most effective and efficient healthcare to bring us into parity with the other wealthy nations. And what we have is this nexus of market failure, which is based on the unique situation in the United States. So we've got pharma. I'm an expert in pharmaceutical company behavior, so I'm going to focus on them. We've got pharma at the center of this nexus, and we have pharma having relationships with each one of these six categories of organizations that's beneficial to pharma and beneficial to the organizations, but not beneficial to you and your families as consumers. So let's start here with the medical journals. We were talking about that. So pharma has control over the information. The peer reviewers don't get to see the information. The journals buy, the drug companies buy the articles back from the medical journals. So the medical journals have a tremendous financial incentive, if not imperative, to make the pharmaceutical companies happy in what they publish. And we have nonprofits like the Alzheimer's Association, or the American Diabetes Association, or the National Academy, or the National Mental Health folks. These nonprofits, and I think we kind of need air quotes around nonprofits, because most of them receive a significant amount of their funding from the drug companies. So when the American Diabetes Association, or Rheumatological Association, or whatever, when they make recommendations to their patients as nonprofits, what they're really doing is laundering pharmaceutical money to make it look like it's not for profit and disinterested, but it's not. And then we get into the patient advocacy groups that I merged here. The guidelines are really important because doctors have to practice based on guidelines. If they don't, the guidelines are admissible in court if things go wrong, and things always can go wrong, whether you practice, however you practice. But the guidelines set a standard of community care that's admissible in court. The problem is that the guidelines are based only on the published articles from the journals. So those articles are not completely vetted, and yet the guidelines are formed and adopted into use as if they scientific evidence were vetted. And a quick anecdote, I wish there were an antidote. A quick anecdote is I saw an error in the United States Preventive Screening Task Force guidelines for the use of statins. I saw that the benefit of statins for one of the drugs was grossly over the data wasn't supported. And I called up a friend who had been a significant player in the NIH and knew the folks at USPSTF and participated with them. And we had a conference call with them. to show them the error, the numbers that they had wrong. And the result of that phone call was I learned how USPSTF, which is the most trusted guidelines, get their data. This is the extent to which they dig into the depths of the data. They get in touch with the primary researcher for an article, and they ask the researcher what are their top line results. And the researcher submits the top line results, and that's all the vetting that gets done. That's it. And the researcher mistakenly, I believe it was in good faith or not in bad faith, the researcher submitted the wrong data, and it just got published, and it doubled the benefit of the 2016 USPSTF guidelines reported the benefit for statins. It doubled it. There was still some benefit shown, and we're going to be talking about those issues on Friday. But the capture of the regulatory agencies, 9 out of the last 10 FDA commissioners have gone to work for the pharmaceutical industry or financial organizations that serve the pharmaceutical industry investments. So the FDA commissioners clearly have an incentive to keep the pharmaceutical industry happy because they're going to work when they get out. The researchers need to do it because they want to be researchers and they've got to play ball with them. So we have this nexus of market failure and we have no way to straighten it out. You need to have government straighten these things out, straighten out a market failure. So the successful healthcare reform must include restoring epidemiological balance to the medical research agenda. It must include that, not 4% for the real guts of what makes a population healthy and 96% for drugs, but you need to invest in research that represents the public's interest, not the corporation's interest. And in order to do that, there needs to be some way, and you need a government to do this. I know there are a lot of libertarians who are on the right side of a lot of issues and are for downsizing government. But this is a function that you need government for to oversee the research agenda. So what we take as knowledge is going to make us actually healthier and not waste our money. B, ensuring the accuracy and completeness of the evidence base of clinical care, which requires transparent peer review. It is crazy that doctors are taught and must practice medicine in accord with the articles that are published in peer-reviewed journals when peer review is a sham. C, implementing health technology assessment to evaluate the cost effectiveness of new drugs and devices to inform healthcare professionals, guidelines, and coverage decisions. And in this, the US is pretty much unique. We had the first health technology assessment, and in Newt Gingrich's contract with America in 1995, he zero funded our health technology assessment. Now we had the first one, but we are now standing alone without health technology assessment. And we've got to control the price of brand name drugs, not just because they're expensive, which they are, costing about 3.5 times more than other wealthy countries, but because that excess money creates a marketing impetus that pushes these expensive new drugs, only 1 out of 3 or 4 of which are actually better than previously available therapies. But the high price makes the marketing cost effective. So Ubrelvy, you're seeing all this marketing for a drug that's only a third or a quarter as effective as the old-fashioned migraine drugs. But the Ubrelvy is being pushed onto your TV screens because of its profitability, that it costs $100 a pill. There's a lot, the patent's still on for Ubrelvy, and there's a lot of money to be made. So doctors require adequate information to function as learned intermediaries. And I want you to think about that picture of the slaves chained in the cave, looking at the shadow of the horse. That's the position doctors are in. And the doctors need to take control of this. They need to say, we cannot work if we don't have access to the real data, and if we don't have a statistical analysis, an unbiased statistical analysis of the real data before it's published. We can't work. We can't take care of patients like that. And finally, true reform will require a coalition that includes the public, healthcare professionals, and businesses that purchase health insurance for their employees. But in that context, we see that the party breakdown for pharmaceutical industry contributions is about even. And 2/3 of politicians are getting paid off by the drug industry. So they're part of that circle of market failure. The politicians need to be in there too, with their relationships with pharma and what their incentives are. So none of these reforms can happen until the political influence of the manufacturers' the political influence of the manufacturer's financial resources is curtailed. That's a tough ask. With Citizens United and unlimited amounts of corporate money being able to go into campaigning, the drug companies can take their money that they gave to the politicians and multiply it by 1,000, and they still won't get hurt. Healthcare professionals, government officials, and most importantly, the public understand this is what has to happen for reform. The public understand how our healthcare system has become a servant of the industry and not the reverse. Finally, stakeholders need to become activists. Now, this is an article that was published yesterday, and it's very important to include it. I'll just take a couple more minutes here. But this was published yesterday in Health Affairs. It takes several months for an article to get published, so you can't blame it for being a little bit behind the times, because obviously the context in which this is unfolding is changing rapidly now with President Trump. Confronted with stagnating life expectancy. Now, that in itself is a misstatement, because we don't have stagnating life expectancy, we have declining life expectancy. In the wake of an unprecedented pandemic, the country faces a stark choice. We can choose to treat prevailing economic thinking on health as a law like the law of gravity, pulling us inexorably on our current path. This is the path that I've described. They're aware of it. And they're saying we can choose to say that's a constant, we can't change it. Or we can build a new common sense following the pioneering examples set by prior generations of Americans, striving to improve the health of the nation, from mobilizing the sanitary movements of the 19th century to launching Medicare and Medicaid in the 20th. Our era calls for bold action on no less a scale. Now, this is so 2024, because everything has changed in the last couple of weeks. What we have had since 1980 is a situation where the drug industry and the other corporations, insurance, PBMs, hospitals, have controlled the flow of information and have controlled the services that are offered to the public. And the healthcare system has been set up to serve those financial interests. That is so 2024, because now we're on new turf. All that is going to continue to happen, that the vested interests in healthcare will attempt to control the system to serve their interests primarily. But now we've got a new situation with President Trump, where he is very worried about tax cuts for the wealthy and the amount of money that will be shifted up to our billionaires and multi-billionaires. That's part of his agenda. And when he's going to think about cutting healthcare, when his administration is going to think about cutting healthcare costs, which are way too high, twice as high as they should be, they're not going to do it with a scalpel. They're going to do it with a machete or an axe or a chainsaw. And their job is not to have the maximum financial benefit for the healthcare industry, but to have the maximum transfer of wealth from working Americans up to the billionaire class. And that's the new situation that we're in. And God knows how it's going to play out. But I beg you to understand what's going on here, the nature of this problem, the critical juncture we're at, and how a sine qua non of a remedy is for the public to become aware of what has been a financially dominated system that was designed to squeeze out as much money as it could, is now a system that is going to try to transfer as much money to our billionaire class as possible. So I thank you very much. please send this lecture on to all the folks you know who are interested. I want to be like the guy at the demonstration holding the sign saying, you got to know this. Send this to your friends and family. Have them send it on. Thank you.
Great. Thank you so much, Dr. Abramson. That was a very powerful presentation and one of the reasons why you're one of my favorites. So my only regret is we have about 14 minutes for questions, and I have a few pages here of questions that I generated during your talk. Real quickly, what happened in 1980? Right, that was Jimmy Carter. Jimmy Carter was president in 1980. Reagan came in 81. What happened in 1980 that
I'm having a
precipitated
hiccup
all
in my
this change?
screen. I'm not sure if you are.
Yeah, John, have you? Oh, you know what?
Okay,
Actually,
now I'm
I'm
back.
sorry, John. You know what? Actually, before we get into that, so thank you, John. So I wanted to give people the opportunity to see your book and let people know where they can get in touch with you and how they can get your book.
So my book's available at all booksellers. So go get it, please. This is I was in litigation for about 16 years. I spent 6 years writing this book so that it would be understandable for the public the way I hope this lecture was understandable. And you can't really understand what's going on without this book. So buy the book, buy it wherever you buy it. My email address is pretty simple, John Abramson MD at, John Abramson MD at gmail.com. And if you have questions, let me know.
All right. So maybe I'm gonna have to ask all my questions through your email. So what happened in 1980 that precipitated all of the changes with regard to what basically what you were talking about?
Yeah, that's a really important question. What happened is that the right in the United States had been growing in power since Goldwater's dramatic defeat in '64. And the think tanks on the right went to work. I think probably analogous to Project 2025, but this was back then. And what they were looking at, and President Reagan came in, and there was a shift in the tax rates. So the maximum tax rate went from 90% way down to, I don't know, 30% or something. So the key issue that changed was the distribution of wealth in the United States. And that's bad for people's health. And the distribution, the maldistribution of wealth in the United States is greater than the maldistribution of wealth in the other developed countries. And it got worse in those years. That's the key. But for our purposes in healthcare, what happened is this private enterprise ethos took over the healthcare research part of creation of knowledge. And that's where the commercial entities could grab as much money as they could and make it look like it was based on scientific evidence.
Great, thank you for that. On slide 39, you were talking about that's the one we were talking about, like the 21.2% of responders were had a benefit compared to had a benefit compared to placebo, which had like around 10%. Does that 21%, does that mean that out of 100 people, 20 or 21% felt it? Or I'm a little confused with what those numbers were.
Yeah, out of 100 people, 100 people with an acute migraine, 21.2% didn't have those symptoms at the end of 2 hours.
Okay. And then
21,
so you subtract out the 10% of the placebo effect and you're left with 10%. So that's the 1 in 10 number. Thank you
that's exactly right.
for clarifying. Do insurance companies invest in pharmaceutical companies either directly or indirectly? Are they allowed to?
That's a very good question. They don't. And one of the ways to break industry's lock on this is just to start making drugs effectively. California's getting into the insulin business. And this craziness of the $300 per vial insulin is going, the truth is, and now you're going to take the $300 vial and you're going to cap the cost at $35 a month for consumers. The truth is that it costs much less than $35 to make. So the government capping costs at $35 is just socializing that excess cost that's being paid. And California and others are now acting on making their own insulin for $35 a vial. So there can be workarounds, but it's very hard. And the industry really has a grip on producing the products that doctors and people trust. And that grip's got to be loosened, but it won't be loosened until people understand these issues that we're talking about. The public has to understand. It's just like the demonstrations on Saturday. The public has to understand, except this is much more complex. It's much less visible than what's going on in politics. But the public has to understand this, and doctors have to understand this, and both parties have to demand that this be brought back to a common sense position where the American people's health is priority, not the profiteering.
So you had a slide where you went over Replax versus, and you were talking previously about Ubrelvy, I believe is how you pronounce it.
Yeah.
And you're basically showing how the Replax is more affordable and works better compared to the Ubrelvy. Is there any site to your knowledge that shares that type of information so that people could go there and see a credible site to see what works?
Yeah, so good. So this is the key question. This is the issue. What I showed you is the FDA approved label for both of those drugs. Go to FDA access data and put in Ubrelvy or the other drug, and you'll get the label. There's no more credible information than what the FDA includes in the drug label. Now, except credible has to be taken from 2 points of view. If you want to define credible as the most likely to be factually true, that's the FDA label. If you define credibly as the socially accepted definition of what's true, then that's what's in the journals and the marketing and the advertising. That's not credible. The FDA's label is credible. So if people say, holy moly, that's such a difference, and the cost is, it's so hugely different between the two drugs for each headache prevented. How can that possibly be true? The FDA label says that, and the fact is that the drug companies own their labels. They negotiate the labels with the FDA, but they own the label. Now, doctors aren't taught to look at those labels, but that's your quickest path to credible information is the drug label. The front page tells you what the indications are, and section 14 shows you the clinical trials that the company chose to put in the label. So don't think because you're reading that in a drug label and it's not the New England Journal of Medicine that it has less validity. It has way more validity. That's the source of information. But the meme and the sociology of this so-called knowledge is that you need to read it in the New England Journal, not the FDA approved label.
Thank you for that. All right. So why does Pharma have such control over the US, but as evidenced by the research in the country comparisons, as opposed to other countries? What is it about the United States that has allowed for this? And what is it that prevents it in other countries, or at least minimizes it?
Yeah. I think it's pretty clear that Citizens United changed everything. When companies can put unlimited amounts of money into political campaigns and threaten to put them into campaigns against legislators who don't support their agenda, it's powerful. I mean, that's how politicians work. They work on the contributions that come in. They attend to the people who pay for them to keep their position. And that's the primary difference. The other difference is a cultural difference where there's more of a sense of social cohesion and a commitment to the public's welfare as opposed to individual welfare in the other countries than there is in the United States. That makes us different. It makes us a powerful engine of innovation, but we need guardrails on that. We're out there alone. We're in a wild west of gloves off capitalism, and we need to have some guardrails, and we're going in the wrong direction.
So, who else is doing this kind of work?
Um, there are a lot of people who are doing this kind of work. I think if people want to see sources, a couple of sources that I would recommend is the Therapeutics Initiative. Yeah, is out of the University of British Columbia in Canada, and they do I think, the best uh, critical evaluation of publicly available knowledge. The Therapeutics Initiative, if you just Google them, and if they've covered the issue that you're interested in, you're going to get the best analysis of publicly available information. Public Citizen issues a book called uh, Bad Pills, Bad Pills. And that too is an excellent source of information.
What was the name of that organization?
Bad Pills, I think it is. It's Public Citizen does the book.
Okay, thank you. And can you restate the difference? You're talking about what was it? Paxlovid, and you had two studies, and one was the HR and versus the SR. What can you kind of restate that real quickly? And we actually have like 2 minutes. You know what? Actually,
Sure.
before I ask you to do that, just because we are going to wrap up, and I have a feeling that your wrap up can be 2 minutes in and of itself. Do you want to end, take 2 minutes, and just kind of make a statement of what you think,
No,
what gives people help? How about
I'm
that?
sorry.
What gives people hope, or what gives you hope?
What gives me hope is what we're doing right now, is sharing this information and becoming realistically educated about the situation that's going on, and hoping that you folks who are watching this lecture have found it meaningful and will pass it on. The key is pass it on. Um, uh, Books like mine don't get support from the media. They don't get covered in book reviews. And this information is critically important. It's systematically canceled from the public consciousness. So please pass this information on and have those people pass it on. The Very quickly, the Paxlovid study, the first study included people who were unvaccinated and had no antibody evidence of ever having had COVID. So they were bare. And Paxlovid decreased serious illness by 90%. But when you do a study that has either people who are vaccinated or have antibodies or both, then there is not a significant benefit to Paxlovid. And
Got
the
it.
problem here is that 98% of people are either vaccinated or have antibody evidence of having COVID. So Paxlovid is only relevant for 2% of the people, but the drug ads don't say that. The drug ads make you think that you're being a jerk if you don't go get Paxlovid for $1,500 a pop, I may add.
Thank you for that clarification. So, all right, I'm going to try to get one more question in here, even though we have just a few seconds. With regard to the health outcomes in the United States and the shorter health span, is it because of the healthcare system, or is it because we're already starting off sick? Well, let's say that the food system is so bad in the United States, and that we're coming into the healthcare system obese and sicker.
Yeah, that's an extremely important question. It's not really coming into the healthcare system, are in the healthcare system obese and sick. And that is true. The point, and this is, I'm glad we can end on this, because the point here is that it is the healthcare system's responsibility to address those upstream problems. So we ignore it. We ignore the dependence on highly processed food. And we ignore the lack of exercise that people get. Other countries can focus on those things as health issues. That's why I spent so much time on that slide that compared health spending to social service spending. It's our whole society, but healthcare can't be just isolated and say, no, 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 we just deal with prescribing things and doing surgery on people. That's the problem, is that the docs are taught that in medical school, and they're not taught that their responsibility is the well-being of the population. That's the key point.
Great. Thank you for that. And that ends our time, unfortunately. Well, thank you so much for all the information that you shared. I'm excited to talk to you again on Friday. I'm hoping your lecture isn't quite as long so I can get some more questions in, because I have so many questions. But do what you got to do. It's such great information. And as we can unmute the audience so they can share their appreciation for Dr. Abramson, please.
Thank you so much. Amazing. Amazing information.
Thank you.
Amazing.